My role today is to explain a little bit how Prefer sees the application of preference data to inform health technology assessment decision-making. Yes, my name is Irina Cleemput. I work for the Belgian Healthcare Knowledge Center. I'm a senior health economist and scientific program director. This is the outline of my presentation. First, I will just recapitulate a little bit what has been said before. What can we learn from patient preference studies? This can be very brief, of course. But then why is it relevant for health technology assessment? How can patient preference data be used in health technology assessment? And shouldn't we use public preferences? This is, for those who are familiar with HTA, something that you frequently hear, of course, is that maybe it's not patient preferences we should look at, but rather public preferences. And then finally, I will discuss an unresolved issue about the application of patient preferences in economic evaluations in particular, and also suggest a solution to these unresolved issues. So what can we learn from patient preference studies? Just in summary, what we've heard before, patient preference studies can inform us about what matters to patients, how much it matters, and which trade-offs patients are prepared to make. So again, what is most important to patients? And before we dive into the precise question on how patient preferences can inform health technology assessment, I would like to highlight once again what the actual purpose of HTA is. And the actual objective of HTA is often, not always, you have specific cases of HTA, like for hospital decision-making, but very often the objective of HTA is to support reimbursement decision-making. And HTA tries to do this by making a full overview of all the relevant aspects related to health technology being a medical device or a pharmaceutical product. It can be any type of medical product or technology, even diagnostics or rehabilitation interventions. So HTA makes a critical assessment of the available clinical evidence on safety and effectiveness of these technologies. But also, and that's a very important part of HTA usually, by performing an economic evaluation. And this economic evaluation assesses the value for money of this health technology. So what is the added value, and is the added value worth the usually additional cost of this technology? A third large domain in HTA is the discussion on patient and social issues, and then finally also the legal, ethical, and organizational aspects related to the implementation and the use of new medical technology. So that's the context HTA has to work in. So it has to inform reimbursement decision-making, which makes it, of course, very subject to also the trade-offs that need to be made between the societal needs and the individual needs. So it's impossible for HTA to focus only on the individual patient needs, because there is a societal reality behind each decision about reimbursement, and that is that resources are limited and we just cannot reimburse or cover out of public resources everything that we would like to. So we have to make choices, we have to make trade-offs, and this is what HTA should take into account when making its assessments. To make this decision-making process a little bit more transparent and divide it in smaller pieces, smaller decisions, we developed in 2012 a framework for decision-making on reimbursement. And what I try to do on this slide is to highlight where patient preferences could come into the picture in each of these questions. So the first question would be, does this product target a therapeutic and societal need? Now, the therapeutic need is obviously something that is informed by the patient's needs and the patient preferences. So what matters most to patients? So obviously, when assessing therapeutic need, we need to know and we need to investigate what matters to patients and what matters most to patients. So just to know whether there are indeed needs that are unmet for patients and which can be met by a new medical intervention. When we are talking about societal needs, of course, we will rather look at societal preferences. The second question is about the willingness to pay from a societal point of view for a treatment that would improve the indication. So that's really a principal question about should this be paid for by the patient himself or should society pay for this? And this is also a matter that should be discussed from a societal point of view, and societal values and preferences would come into play. The next point is, are we as a society prepared to pay for this particular treatment? And this is a very important part of HTA. So the relative effectiveness of the new medical product or medical intervention will determine to a large part the willingness to pay for a treatment. So relative effectiveness assessment means that you will look at the effectiveness of the new intervention and compare this with the effectiveness of the existing intervention or the current standard treatment for this condition. And of course, what is important in this relative effectiveness assessment, and this is something that we argue within PREFER, is not only the purely clinical outcomes like survival or or disease-free survival, for instance. But what we should look at is whether this new treatment really improves the outcomes that matter most to patients. So that is why it is so important to first investigate the therapeutic needs of patients and to investigate what patients want to see improved when a new treatment comes. We want to take this into account in the relative effectiveness assessment by giving the right weights to the outcomes that matter and that matter most to patients. Are we prepared to pay more for this treatment than the best alternative? This is obviously something that we should not ask the patient, but this is a societal decision because it is eventually society that pays for this additional cost. And how much more are we willing to pay out of public resources is also a societal issue. So let's return now to the medical product life cycle. Where do we see the application of patient preferences with relevance to HTA when considering this medical product life cycle? When we start at the very early phases of medical product discovery and development, we argue that we want to understand patients' views on what matters, and in that case, we should identify them very early on. So even in the very early phases of the medical product life cycle, we should try to identify patients' unmet needs or patient needs to inform what kind of clinical and non-clinical outcomes should be included in the clinical trials that are set up later on in the context of a registration request and the eventual reimbursement request. We argue also that this should actually be product independent. You should go to the patient population with a specific indication that is targeted by the medical product, and you should ask these people, these patients, what are the things that matter to you? What do you want to see improved when a new treatment or a better treatment would become available for your specific condition? And this is important. So this is important for HTA because if you have done this right, then you can use this information in your relative effectiveness assessment, because you will return to these patient needs and you will weigh the outcomes of the new treatment according to what matters most to patients. So you will use this endpoint in the relative effectiveness assessment. There are, of course, other applications, and I will not go into these now because I think we will focus here in this presentation mainly on the HTA and reimbursement. Now, let's focus a little bit on this application in relative effectiveness assessment. So, as I said before, relative effectiveness assessment is one of the cornerstones of HTA. It's very important to do this in the right way, but there are different ways you can do this. And this is just one example. Suppose that you have a new treatment for a specific disease that is already for which there is already a treatment available, so you have a standard of care. But patients suffer still from a lot of fatigue, from hair loss, nausea, and treatment burden with this existing treatment. So your patients highlight that these are the things that matter to them and that they want to see improved if they want to get a better treatment. So clearly, these are very disease-specific attributes for which you can use patient preferences in your relative effectiveness assessment. So whenever a new treatment comes up and asks for reimbursement, you can consider whether this treatment is as effective as the existing treatment in terms of hard clinical outcomes like overall survival, but at the same time also improves on these patient-specific, disease-specific and patient-relevant attributes like fatigue, hair loss, nausea, and treatment burden. But of course, this is a very indication-specific approach. And as I said before, HTA usually needs to take a broader societal perspective to inform reimbursement decision-making from societal point of view. So while the focus of a single health technology assessment is on one particular intervention for one particular indication, the scope of HTA is always larger. It has to work within this larger societal context. And there the question is, of course, the question the decision maker wants to know is, how can I allocate my resources efficiently in the healthcare system? This is something HTA has to take into account when making the assessments. So the question, and this is the unresolved issue I was referring to, is whether we should integrate patient preferences in cost effectiveness evaluations, in budget impact analysis, and in broader value frameworks. Because this is the second large cornerstone of HTA, that is that economic evaluation, the cost effectiveness analysis is its value for money. And when you look at Europe, you see that there are two different types of systems in place. One system is the one that looks at interventions within one indication. So this is, for instance, the case in Germany, where the incremental cost effectiveness ratios of different interventions for the same indication are compared. And then with a given budget for that indication, the resources are allocated to these interventions. So you choose the best, the most efficient health technology for treating that specific indication. But other countries like the UK, for instance, say, no, we don't have to look at one specific indication. We have to allocate our resources efficiently across the entire healthcare system. So we need to be able to compare the incremental cost effectiveness ratios for different indications, so across indications. And this has implications for the relative effectiveness assessment that you do in your health technology assessment. For instance, in this case, when you only look within indications and you allocate your resources within an indication, you can use disease-specific outcome parameters in your relative effectiveness assessment. Because these, as I said before, if you do a product-independent assessment of the patient needs within an indication, you can use these patient-relevant outcomes, disease-specific outcomes, in your relative effectiveness assessment. And you can then also use, of course, patient preferences for these different outcomes. If you want to make between indication assessments, that is not sufficient, because you need to be able to compare the outcomes of different treatments for very diverse indications. So you need generic outcome measures, like, for instance, the quality adjusted life year, where you look at life years gained and changes in health-related quality of life measured by means of a generic outcome measure. So you have generic attributes. And because you need inter-indication comparability, you would not use patient preferences because they are not comparable between populations, but you would rather use public preferences. Another point I wanted to highlight is the importance of patient preference information for budget impact analysis. It has been explained by Bennett before, the preference study about the acceptability of benefit-risk trade-offs of the new versus the standard treatment can inform the decision maker about the possible uptake of a new treatment, the so-called choice share. Same applies for the preference study about the acceptability of uncertainty. So that will give you an indication of how many patients would be willing to take this new treatment instead of the existing standard of care, for instance, in the context of a managed entry agreement when there is still a lot of uncertainty. And this can inform your budget impact analysis. So in summary, I think I explained that patient preferences can be used in HTA on several occasions. For instance, when identifying the patient needs, which is information that you need for the relative effectiveness assessment. You can use it in budget impact analysis to identify the potential uptake of your new treatment compared to the standard of care. For cost effectiveness analysis, it depends on what type of system you are working in. It can be patient or public preferences. And the same applies to organizational aspects, where also it is patients and public preferences very often. For societal needs, you would look at public preferences, and for patient issues, of course, it's mostly patient preferences. And with that, I would like to hand over again to Connie, who will moderate the discussion. Thank you very much for your attention.